On behalf of the Duke Margolis Center for Health Policy, I'd like to welcome all of you to our webinar on Bridging a Care Gap, Policy Opportunities for Improving Access to Home-Based Primary Care for Rural Populations. I'm Mark McClellan. I'm the director of the Duke Margolis Center for Health Policy, and you'll be hearing from us as well as experts and stakeholders on these topics during the next hour. This is a very important topic and really appreciate your joining us, including those of you from the West Coast. I know it's quite early there. We've got a great panel that will talk about the unique opportunities and challenges for promoting equitable access to comprehensive longitudinal care in rural areas through more comprehensive home-based primary care models. This is an important topic. There are nearly 2 million older adults who are completely homebound, and over 5 million with complex health and social needs who face difficulties and barriers in seeking and receiving coordinated prevention-oriented care in traditional brick and mortar settings. At the same time, there's a significant gap between the demand and the supply of these more comprehensive home-based primary care services, and these challenges are going to worsen with our aging population. This gap is especially problematic in rural areas. Rural adults are 78% less likely than those in large urban metropolitan counties to receive home-based care. In addition, rural adults are on average older. They have higher rates of chronic disease and disability and have significantly greater unmet mobility needs, frailty impairments, and otherwise compared to urban residents. The home setting is an undertapped, underdeveloped resource to provide care to the millions of people in the United States who are unable to access or have difficulty obtaining care in traditional settings today. Home-based primary care is not only a basis for a patient-centered model addressing many people's preferences to be at home and meeting people where they are in their community, but also an opportunity to deliver more coordinated longitudinal care, potentially more efficiently by building in technology and supports right there in the home. The demand for home-based primary care has been growing. It's likely to continue to intensify as our population ages, indicating the need to develop age-friendly health systems that support evidence-based practices, efficient, effective practices targeted to the needs of individuals in these home settings and addressing what matters to older adults and their care partners. This is an issue that is part of the priorities of our policymakers in advancing home-based, coordinated, comprehensive primary care. The Centers for Medicare and Medicaid Services, as many of you know, is committed to having all Medicare beneficiaries and vast majority of Medicaid beneficiaries having access to accountable, coordinated, longitudinal relationships built on a strong primary care foundation by 2030. And while there's been progress in reaching that goal, we still have a significant ways to go. To make more progress, it's going to require supporting and engaging home-based care providers, rural care providers in these accountable care models, in these models for advancing primary care to support more comprehensive, equitable access and reach that CMS 2030 goal. In turn, this requires thinking about the payment reforms that are being implemented and the care delivery models that they're intended to support to efficiently and effectively meet the distinct needs of rural populations and the providers who serve them, and the additional time it takes to reach these patients, the issues with supporting them through telehealth, broadband services, and other special considerations like that. So a lot of important issues to discuss. Before we turn to our panel, I do want to thank the supporters of this critical work. The project and today's workshops are supported by the John A. Hartford Foundation, which is dedicated to improving the care of older adults through evidence-based, person-centered approaches to care. And in particular, I especially want to thank Ronnie Snyder, Vice President for programs at the John A. Hartford Foundation, who is joining us today. Ronnie has over 25 25 years of experience working with preeminent healthcare institutions across the nation to improve the care of older adults and make these kinds of care models more widely available, identifying and guiding healthcare programs that are setting the standard for effective medical practice, increasing medical education opportunities, and maximizing resources that are directed to these steps to increase care coordination, value of healthcare for the patients who need it most. She brings that experience to the John Hartford Foundation, where she coordinates initiatives that foster collaboration among academic institutions, hospitals, healthcare providers to build age-friendly health systems, support family caregivers, and improve serious illness, end-of-life care for some of the nation's most complex patients. She's a board member and past chair at Grantmakers in Aging, a membership organization comprised of philanthropies with a common dedication to improving the experience of aging. She's also a board member for the American Society on Aging, a fellow at the New York Academy of Medicine, and she's previously served as a volunteer long-term care ombudsman for the state of Nevada Aging and Disability Services Division. So Ronnie, thanks for being here. Thanks for your long-term support for this effort and for helping us move these reform approaches forward.
Thank you so much, Mark, for that generous introduction. I'm really excited to be here, actually. And I want to send our thanks right back to you and to the Duke Margolis Center for Health Policy for all of the work that you're doing in this really, as you say, a very important space, and also to everybody who has joined today's webinar. We're excited to discuss the practical policy opportunities to ultimately increase equitable access to home-based primary care for older people in rural communities. And we are, as you say, headed toward that 2030 CMS goal. The John A. Hartford Foundation is a national philanthropy. We're based in New York City, but we operate all across the country, and our mission is to improve the care of older adults. So we do that through 3 different priority areas to get to that mission. They are creating age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. You can hear this work reflected in all 3 of those areas. Our foundation supports home-based primary care because of its alignment with our age-friendly health systems movement, among other things. Age-friendly health systems are designed to equitably deliver evidence-based care that reduces harm and centers on what matters to older people and their family caregivers. Home-based primary care, which often, as we all know, includes home-based palliative care for people who have serious illness, provides a much-needed age-friendly option for the millions of homebound and home-limited older adults and their families. We see home-based care as, by its nature, person-centered. It brings healthcare to people rather than the reverse, and that's why it aligns so well with what often matters most to older adults, which is staying at home rather than being in a hospital or a nursing home. It's team-based care, and it can be a lifeline for homebound older people and other patients who have the most complex and the most costly healthcare conditions. So as we expand home-based primary care, we continue to consider the unique challenges that are facing rural communities, which are less likely to have access to home-based care. Today's discussion about policy options can facilitate rural home-based primary care. Fits really well with a new initiative that we are funding that we've been developing with the National Rural Health Association to bring age-friendly care to rural communities. So today's discussion and other work that we support at the Duke Margolis Policy Center also fit within a larger initiative that we fund to promote primary care in the home. We support the National Home-Based Primary Care Learning Network, which runs quality improvement collaboratives, the Home-Centered Care Institute, which delivers training and education, and the American Academy of Home Care Medicine, which has launched a house call finder, a practice directory for the public. So I encourage anyone who wants to learn more about all of these projects to visit. You can subscribe at our website, johnahartford.org. But mostly, we're just really, really pleased that you're here to learn, as are we, as am I today. So big thanks to all of you. It's important to us that together we can ensure that more rural older adults have access to age-friendly home-based care. So with that, I turn it back to you, Mark, and the Duke team.
Great. Thanks very much, Ronnie. I really appreciate those remarks to help kick us off. I also want to thank Jonathan Gonzalez Smith and Montgomery Smith, no relation, who have been leading this work with the center. And with that, I'd like to turn to Rob Saunders to kick off our panel discussion.
Thanks, Mark. And I'm excited to be able to flag this and start this conversation, really talking about what lessons we've learned from the field on improving home-based care for rural communities. And I'll ask the panelists to go on camera at this point, and I'll do short introductions, which I'm not even remotely going to do them justice because we have a really great panel today. But just giving a quick set of introductions so that you know who's going to be talking with you for the next about 45 minutes. We have Carrie Cochran-McLean from National Rural Health Association, where she is the Chief Policy Officer, and there is not only focused on how to drive that policy agenda for rural healthcare for her member organizations, but also is bringing to that a long amount of experience with leadership roles at HHS, with the Federal Office of Rural Health Policy, with other groups, and that have really been thinking about rural healthcare. Also here is Kristen Dillon, who's the Chief Medical Officer at the Federal Office of Rural Health Policy, where she is thinking about and providing advice on the clinical and rural healthcare, not just in that office, but broadly across HHS. She's come into this role with a long-time experience as a family physician in Colorado and Oregon, so is able to take those practical on-the-ground experiences and apply those to the policy roles, and has long-time experience also with the state of Oregon and their Medicaid program more broadly with COVID response and also with the U.S. Congress. We've also got Elizabeth Foster, who's also going to be bringing frontline experience in rural healthcare today, who is a lead clinician for the Connected Care for Older Adults and is helping think through how to improve care for older adults in rural areas in the state of Oregon. A lot of Oregon today, thinking about age-friendly healthcare. And is also thinking through, has worked in a variety of settings providing care to older adults and in rural healthcare, including community health centers. And so it's going to be able to bring sort of a broad range of experience into that. And rounding out our panel is Amar Kindle, who is the president of Homebound Health, a company focused on improving access to comprehensive care for older adults in rural communities. Amar is coming to this work not just from Homebound Health, but also from senior leadership roles at Livongo and at Teladoc, so is also able to think through some of the technological means that we might be able to use to provide access to older adults in rural settings. So that is our panelist for the next 45 minutes. And maybe to kick things off, would really love to just start by talking about why is this important? You know, why are we even talking about improving access to healthcare, especially in the home for older adults in rural areas? And Kristen, if you don't mind, I'm going to have you kick us off there.
Sure, happy to. Thanks for that lovely introduction. I mean, I think some of the introductory context comments help to set the stage, but I do think it's important that, we understand the context of where the communities are trying to help and what may be shared, what may be unique about them. And I guess, I mean, one of the key things about rural communities is they're less densely populated than the rest of our country. That's the definition. But it tends to mean that people, you know, when they are living in groups or communities, they're much smaller. They're communities of a few hundred or a few thousand, and that other folks, you know, live at significant distances from each other. I'm the medical director at the clinic in Sherman County, Oregon. It's 45-minute drive from that clinic to the nearest retail pharmacy. We have patients who regularly drive from isolated homes out in this wheat farming, ranching communities. People drive 30, 40 minutes just to get to our clinic. And then, you know, it's another to get to something else. So just the distances, and that brings with it, particularly for work trying to be done in the home, significantly increased travel time. Also, we run into things like worse roads, difficulties with broadband access, difficulties with cell phone service. I had the experience a few months ago. I used a shared electric car from the community where I live, which is more populated, and took it out to clinic and actually couldn't get back in again at the end of my clinic day because there's no cell phone data service where the clinic's located. And I had to have someone open the clinic and get on the Wi-Fi. And anyway, so there's all kinds of unexpected developments, and just being ready for that. We heard about the fact that rural America tends to be older than the average of our country, with the health risks that come with that. And even when we adjust it for age, the burden of disease for rural residents is higher. Chronic lung disease, especially. Also, many of the other chronic diseases impact people at younger ages and more severely. I think when we think about rural communities, we think about rural America as being white, and that's true for a majority of the residents of rural America, but it's really an error if we get that stuck in our brain. There are many counties in our country that are majority Black, African American, majority Latino, that have large numbers that are majority American Indian or Alaska Native, or that have large numbers of immigrant and refugees who are recently arrived to our country. So I think it's very important, as we're thinking about serving rural communities, to continue to include that diversity and understand that the people we're trying to serve may have compounding challenges around language access or racism, or generational poverty that add to the distance and density issues that we face. The economic infrastructure of rural America is also really under challenge, as we've seen, changes in how agriculture is done in this country, shifts of manufacturing, shifts of population towards the coasts. There's an economic edge as well to what we're seeing in those communities. There's a lot of benefits in small communities. The social glue can be really strong. It often doesn't take that big of a room to get everyone who needs to be involved in solving a problem around the same table. And I've seen an incredible amount of flexibility and creativity, and willingness of people to step up, to go beyond what they're required to do or paid to do or have to do, to meet the needs that they see around them. So there's a little intro about what I see in rural America.
Thanks, Kristen. And I think what I take away from your opening remarks here is that we've got a lot of needs in rural America. I mean, there's a lot of older adults. Many of them have some very strong chronic diseases and need care in the home. And there's some specific challenges to doing that, given the centralized nature. But there's some equity issues that we can help address by providing better home-based care in rural areas. And there's some benefits and some opportunities that we can take advantage of in rural America that can help us maybe meet some of those needs. With that, actually, Beth, I want to pick up on some of the points I think that you might want to make here, which is you're on the front lines every day thinking about delivering care directly to folks in rural America. You've got a specific care model that's able to really think through how to tailor the work that you're doing based on the unique needs of the community. And wondered if you could talk a little bit about your pilot, how you've been able to operationalize it, and what are some of the challenges you're seeing in scaling that type of work?
Well, thanks for the opportunity to be able to talk about our work. We've just finished the first year of a pilot model that targets frail older adults in rural areas who are living at home, especially people who don't have access to home health and on-town hospice or don't have other support systems. Primary care clinicians refer eligible adults to community health workers, and they implement clinical protocols based on age-friendly healthcare and what matters: medication, mobility, and meditation. Sounds like this audience is very familiar with age-friendly healthcare, so that's helpful. They provide education information, connect patients with resources, and refer them back to clinicians for further assessment support when needed. They work closely with the patient primary care provider, and I think we found in the first year that the program has been extremely well received. It's meeting the needs of patients. It's meeting the needs of overburdened rural clinicians. It's been streamlined so clinicians only get the information they need. And it also focuses on, I think, things that Kristen mentions, that care and resources that people can't access from home. For example, there was one gentleman who had been working to get hearing aids for over 2 years, and he was unable to interface with the care providers in a way to accomplish that. And the community health worker was able to facilitate that. Another man became homebound and could not get out of his home and needed help getting a ramp so that he could get in or out of his home. I think that in terms of delivery models, meeting the needs of patients and meeting the needs of primary care clinicians is critical. And I think it's also important to build on the primary care home, the medical home, and to reach out to high-risk patients who are at home with appropriate follow-up and knowledge of local resources and that ingenuity that Dr. Dillon mentioned. Yeah, I think what's impressive is in our first year, for example, a quarter of our patients were Spanish speaking. More than half of our patients live in the county in Oregon that has the highest percentage of older adults, over 35% in that county are over 65. And one of the clinics doesn't have regular primary care clinicians. They work on a locums basis and has no access to hospice or home health. So it's pretty great to be able to use a resource that we're very familiar with, community health workers, and target protocols in that are based on the age-friendly healthcare to meet the needs of clinicians and patients.
Thanks, Beth. And really appreciate the example that you're able to give of what is able to be accomplished. And Carrie, maybe turning to you next. I know at the National Rural Healthcare Association, you are seeing not just one initiative, but you're seeing a number of initiatives across the country and more age-friendly health systems. And want to hear from you, so that broader landscape, what are you seeing in the terms of that broader rural age-friendly health systems, and what's the current state look like?
Yeah. Thank you. And thanks again for having me here today. So just thinking a little bit, I think for me, taking a step back and as Elizabeth said, I think most of the people on the call know what an age-friendly health system does. But as we think about what this looks like in rural, just as a reminder of kind of the structure of that. So the age-friendly system, it follows the 4 M's. It follows the things that we know are evidence-based. So what matters? Medication, mentation, and mobility. So those are critical pieces of it. We're causing no harm through the model, right? It's there to assist. And I think most importantly, it really aligns with what matters to the older adult and the rural resident and their caregivers. So we know that there are just under 200 rural sites across the country that have this official age-friendly health system designation. And those care settings range everything from kind of an inpatient to a nursing home to an outpatient care setting, which is what kind of we're talking about today with home and community-based care. And when we're thinking about themes for what those systems or models should include, I think it's important to make sure that we've got a full range of access to the needed resources. So not just clinical care, but how are we incorporating some of the social and community-based services that are so essential to keeping individuals healthy. We've got to think about how EHRs are integrating into that, and how is that workflow management happening, and how are those different important partners talking to each other. We've got to be keeping our caregivers involved and recognizing the critical role they play. And then workforce is a huge component of this, making sure we've got an available workforce and that it's trained. And when we have that together in a rural setting, it really can help to alleviate some of the challenges that Kristen talked about, and think about how we can keep our most medically complex, well, maybe not most medically complex, but are more medically complex than the average bear rural populations home and in our communities longer, reducing hospitalizations, readmissions, emergency departments, all of those things while keeping people happy. So a couple of things about what those systems look like in rural areas, and I think also thinking about kind of the home-based component of it is, I think a lot of the issues that we face in rural aren't specific to older adults living in rural, but they're amplified in rural. So transportation, housing, mobility, kind of how do we deal with those challenges? How do we deal with social isolation, which is a problem, I think, among many older adults, but living in rural areas, we know that our rural populations are more likely to report higher rates of loneliness. And then thinking about how broadband and some of the other kind of resource infrastructure pieces are part of it. So those models in rural, when we look across the country, they're using things like telehealth to help augment some of the specialty care access and some of the workforce challenges that we know are out there. We're really thinking about kind of how we're best using our community infrastructure where it's available. So concepts like community paramedicine that we'll probably talk about more today is one that I think is really promising in rural and that we're seeing integrated into more of these models. And then recognizing where there are opportunities to create or identify innovations and coordinating those services in rural. And, rural can be kind of a unique innovation hub in so many ways. And so bringing in new partners or unique partners into how we do this, I think is an important part of that conversation.
Thanks, Carrie. And I especially want to follow up on the point that you raised about the care model for home-based care may look different in rural areas than it does in an urban one, and that's perfectly appropriate. And I want to maybe tee up the panel so that I'm going to come back to that. But Amar, I want to do a deep dive with you before we get to that, to talk a little bit about some of the telehealth issues, some of the technological issues that Carrie flagged here, as I know you've got extensive experience in that, and wondered if you could talk a little bit about how that's being used now in rural areas and where there's some opportunities.
Sure. So, one of the observations that we've made is while during the pandemic we saw telehealth usage increase, it was certainly not a uniform distribution of that increase in telehealth utilization. And unsurprisingly, our rural communities were left behind to a large degree. Broadband availability plays a role, but I wouldn't want to understate the impact of technographic capability. And so we talk a lot about health literacy, and I think in the same breath, when it comes to healthcare, we also need to talk about the capabilities of older adults to adopt new technologies, especially complex ones, especially ones where troubleshooting is a part of the use of technologies that enable access to care. And so the byproducts of that, the results of that are that in many ways, we have to think about deploying technology to rural communities as deploying into austere environments. So it's absolutely true, Carrie's point, that we can't assume that availability to infrastructure is similar to the way it might show up in urban or suburban areas. And the implications of that are we have to take a much more parsimonious approach to the way we use technology and data. But we have maintained those objectives when it comes to quality and access. So as an example, while we don't see much in the way of broadband growth in the way that we hope to see it, high-speed internet being directly plugged into the home via Wi-Fi, we do see encouraging signal when it comes to cellular adoption. And with the emergence of 5G networks, the coverage has broadened and is now covering more rural communities, than had been covered even just a few years ago. So what does that mean? It means that we should be designing solutions that are very bandwidth light and work well on the smartphone without requiring an app to be downloaded, right? Without putting that bar for usage too high for an unassisted older adult to be able to use, without any assistance. And so simple techniques like using SMS as a basis to guide a person to a secure visit on the smartphone are small in the way that we talk about them, but massive in the way that they impact usability. So I think there's a little bit of a shift that's required in the thinking about the way these solutions need to be deployed. The other thing I'd comment on is the essentiality of arming our providers and PCPs, particularly, with the other side of that equation, which is an environment in which they can deliver telemedicine. And so, we've been fortunate to have, through the pandemic and in this post-pandemic period, affordances that make it possible for primary care doctors to get reimbursed for delivering telemedicine. Those are great examples of scenarios that if not protected. And if those things go away, then we're back to where we were before in terms of access. So we're seeing the right evolution of behavior of patients in terms of being receptive to telemedicine in a way that they hadn't been before. But we need to preserve the ability for the provider side of the equation to continue to work.
Thanks, Amar. And so a couple things. So for those of you who are listening to the webinar, we do have a Q&A feature here. And so if you have questions you'd like the panelists to get to, please put it in your thoughts in there. And I and the team are monitoring that and making sure we can bring that into the conversation. We're also now going to shift to having a bit more of a conversation across the panel. And I think the panels have already teed up a number of good issues that I'd love to dive into. And maybe using moderator privilege. Carrie, you brought up a good one here on the care model is just going to look different. And that's totally okay. And so given your perch at the, from this national association, can you talk a little bit about the range of care models you're seeing here? So you flagged community paramedicine as one area that is particularly promising, but are there other areas that are other types of care models that are really helpful? And then would love to pick the other panelists' brains here as well on what are you really excited about when you look at how home-based care is being delivered in rural areas? But Carrie, maybe turn to you to kick us off.
Yeah, I mean, so two concepts. I think the community paramedicine, which assuming this group is somewhat familiar with, is such a fantastic way for us to both help make sure that we're having the important kind of EMS community response capacity in rural, while also taking advantage of the extraordinary skill set these individuals have in helping to keep kind of our older residents and any kind of home-based resident healthy and in their homes. So we think that is one really promising model that we'd like to see grow more. I think another one is, rural areas frequently out of necessity are big innovators, right? And so we are primed to kind of be proactive in approach because it's necessary. It's how we survive the day to day. And so I think there's this concept of the community care hub and how we really think about bringing that innovation into our partnerships between the clinical community, the community-based organization, public health, bringing those partners together and using those community care hubs kind of as a connective tissue to be able to centralize functions and centralize around community resources. Oftentimes in our rural communities, we don't have the same kind of community-based organization infrastructure that you would in a more urban area. And so thinking about how we invest in that and then use that to connect care. I think that's one or two models I would lift up, and I'm sure there are others folks around the room can talk about.
Thanks, Carrie. So community paramedicine, community care hubs, I'm hearing really promising. Kristen may pick on you a little bit here, and given also your national perch, are there particular models that you're seeing that are particularly promising right now?
I mean, I'll second what Carrie and Beth have both raised, that the model may look different. And I think the one thing I'll emphasize in that is the outcomes need to be good. Mm-hmm. We need to ensure that folks who are being served in these models are having good outcomes, their goals of care are being met. And then we need to be fairly agnostic about what exactly the license is of the person who's showing up in the house to make that happen. I guess one of the other things I'll just comment is it is really common in rural communities to maybe have one or two sort of powerhouse organizations that may not be what you are expecting. So it's pretty rare to have a girls and boys club. It's rare to have a YMCA. We often don't have even a medical society in some of these communities or other things that folks are used to. So I've seen, for example, the Community Action Corporation of South Texas started as a community action project with the block grant. They now also run a Head Start program and a federally qualified health center. The Next Door Incorporated, running out of the Oregon's Columbia River Gorge, is an umbrella organization that hosts, 12 different organizations: Big Brothers Big Sisters, CASA for kids in foster care, community health worker programs, mentoring for kids in high school. Because at times you just get to this situation where there's just not enough buildings, not enough good executive directors, not enough board members to run a different organization to do everything. And so then you have to just sort of adjust. You mentioned community paramedicine, but the ambulance district in Washington County, Missouri is another great example of just a really strong organization that's been able to grow and broaden their services to meet the need. And so I guess it's just for anyone who's thinking of doing the work or funding the work, being open to the fact that the organization that's able to step up and do the work may not be who you're thinking of. And so we really work, for instance, in our notices of funding opportunities and how we design our grants to create that flexibility so that we don't assume it's going to be a local public health department that does the work. If Head Start can do it better, then we try to design our grant so that a Head Start organization could also get it. So I guess there's that flexibility. And I can't say enough about the importance of team-based care, both in extending our healthcare primary care workforce, which is spread thin everywhere in the country, and also helping. The benefit we get through that, though, is that when you're using community health workers, peer support specialists, doulas, patient navigators, people are being served by people with whom they feel a particular affinity, in experience, in race, in language, in age. And I think the impact of that commonality cannot be overstated in helping people to achieve their goals and helping them to connect to healthcare in a way that really enables healthcare to meet the patient's need. We talk a good game about being patient-centered, but we're not there yet. And one of the key pieces is being sure the folks who are closest to our patients or clients really get them and can advocate and represent them to the rest of healthcare, so that we do put the person in the middle of what we do.
Thanks, Kristen. And I really appreciate the number of examples that you flagged here, and also the point here that we shouldn't make assumptions on who that lead organization is going to be, and that the flexibility to have different lead organizations can unlock some different care models that maybe we weren't thinking about, but really can achieve some great outcomes.
One thing. I meant to, so when I couldn't remember what the ambulance company was in Missouri that does all the great work. So I went to our grantee, HI Hub. It's ruralhealthinfo.org. Case studies, best, all kinds of stuff. So anything I talked about and much, much more for folks who want to learn this is at ruralhealthinfo.org. All right, thanks.
Thanks, Kristen. Beth and Mara, I know you both are living day to day some of the differing care models, and I know Beth, in your intro, you already flagged some of the ways that you're approaching your care model differently with your community health workers and meeting social drivers of health. But are there other pieces about the care model that you wanted to flag here? Oh, and you're on mute.
How's that?
Perfect.
I think I have been so impressed with age-friendly healthcare and operationalizing that to the point where a high school graduate with a certification in community health work, we've been able to develop these protocols where they can engage patients in concrete ways in their homes about what matters to them, assess their mobility, help review their medication with what's actually in the drawer, and also achieve a rate of completion of advanced directives that we've been unable to complete in our clinics. I think that only in our initial year, only 2% of people had advanced directives. And to Kristen's point, these are trusted people from the community who are peers that people are willing to work with and engage in really difficult conversations, especially advanced directives with our Hispanic community, where sometimes speaking of future possibilities that bad are just not socially appropriate. These community health workers, just in the first pilot, were able to bring in 45% of those patients were able to achieve advanced directives, which is ahead of what we're able to do in the clinic. I think that the knowledge that local people have of resources really performs what I would know from my office in town. They know the local landscape and come up with innovative solutions to how to meet people's needs. There were people who were hoarders and could not move around their houses. There was a 95-year-old taking care of a disabled 65-year-old, and they were able to bring in resources and declutter that house, get additional care so that that they qualified for, so that they could get some assistance in caregiving at home. And I have never successfully found a way to declutter a hoarder's house. I mean, that is just a challenge beyond when you're in the hospital trying to send someone back to a home, to a safe home after a fall. So I've just been really impressed with local knowledge and connection and trust that Kristen alluded to.
And Amar, turning to you, but definitely not least, I would love to hear more about your model. And in the looking at the Q&A, we've gotten a question where folks ask, what are some of the partners that you work with? So maybe if you could answer that in process of talking about some of the difference in care models.
I'd be delighted to. Thank you. And this is such a great conversation, because I think a lot of the comments, Beth, that you just made regarding the model of pairing up a frontline community health worker with a PCP who could frankly be anywhere is a really important component of the way Homeward has approached providing access, creating access to care for the communities that we serve. So Homeward, in broader terms, our approach to rural communities is to take responsibility in a value-based care format to a county's worth of people. This addresses some of the comments that Kristen made earlier regarding density, which is a real challenge to overcome. So by ensuring that we're designing a model for a given geographic area, we can embed ourselves in the community and go very deep. So our approach has been to start with those frontline folks. Typically, we've been leaning on medical assistants, but community health workers, I think, as reimbursement starts to broaden and our ability to lean on them as a resource increases, become an even more valuable and scalable resource. They're backstopped with physicians and nurses, and those individuals can be one step removed. They don't need to be taking on the windshield time, which can be a big driver of cost and limit scalability. But yet, the combination of the community health worker plus that provider who is able to interact with the patient via technology is a really powerful combination. And from an outcomes perspective, it's allowed us to close gaps in care and start to bring the overall quality of care up, thinking about HEDIS measures as an example. It's been a way for us to maintain a very high level of satisfaction from our patients. And this in part comes from the fact that they have a person sitting across the kitchen table from them who's able to spend as much time as they need. And those attributes, together are really hard to find. The idea that you have a care provider who's able to invest the time with you in a safe, comfortable environment, your home, and also the access to a medical professional who can take on those other aspects of more complex care, adjusting medications, making a diagnosis. And so those hybrid models have been very powerful and important for us at Homeward. The other piece of what's made our model very successful is very much to Beth's point. We hire our teams locally, and we think about that hyper-local connection as a critical way for us to address the non-clinical factors that impact outcomes. And it's absolutely true that there's really no way to know what those resources are in a local community unless you're there. A lot of this information is not on the internet. So when we talk about the community center on aging, the local food banks, the opportunities for folks to get eyeglasses at a community events at the local church, they just don't show up in ways that are searchable. And so a big aspect of what Homeward's doing is figuring out how to make those community resources searchable, accessible, referable, and ultimately taking that idea and applying that to multiple communities, because the goal here is to scale a rural health community-based approach. And so behind the scenes, there's a pretty rich technology enablement that's necessary. So how are we indexing these community resources? How are we foregrounding them for our care team at the time when they're most relevant? So when we're in the home and we're identifying a series of needs or risks, how do we make sure that information is easily accessible? If a person's food insecure, how do we make sure we're popping up the reminder that here's a local food bank that can close that gap and help to address those needs? So this concept of really sort of shifting that frontier of access to resources into or near the home, I think, is a very powerful one. One thing you're not hearing me say is that we use a lot of what I'd call national scale resources. And I think things that we take for granted as being easily deployable in urban and suburban areas, this is where one of those lines exists in our experience. Because there's a lot of embedded assumptions when it comes to quote unquote nationwide solutions that really start to break down when you get to these rural communities. I think about, as an example, routine, sort of large scale telemedicine. Things that as we were speaking about earlier, you might take for granted when it comes to broadband, really start to fall apart when you're trying to push those national services into rural communities. And so we have to design things that are more appropriate for the environment in order for them to be adoptable.
Thanks, Amar. And we've gotten some questions in the Q&A, but also I think we wanted to tee up as well on, what does it take to scale a lot of what we've been talking about? So I think we've all talked about some really interesting care models that are able to have produced some really exciting results. Ideally, we'd like to see those scale more broadly across the country and more areas, more rural areas. And there's a number of policy challenges that may hinder that ability. And there's some maybe some other types of levers like payment models that we could tee up as well. And I know folks in the chat in the Q&A have already flagged some of the questions about telehealth, which Mara, I think you started to hint on, and clearly there were some COVID flexibilities and in telehealth policies that were useful. But we also are starting to see more value-based payment models that may provide some flexibilities. So Amar, I might turn to you for this initial question, sort of thinking through the policy challenges. What do we need to do to scale?
So it's absolutely true that rural communities are wonderful places for innovation. In many ways, they create, Carrie's point earlier is that they create a unique environment where there isn't much in the way of competition. And so to introduce a new service, in a lot of ways becomes an easier thing to try when you're not facing a lot of headwinds. And so that's something I think that creates some opportunity. The other thing is interesting when it comes to payment models is that there is a receptivity, and I'd say it's across the entire ecosystem. So one of the big goals or challenges is how do you align incentives between payers, providers, and patients, all three. And in many markets where where there is competition, it becomes even more difficult to find that alignment. But what we've learned is that in a lot of rural areas, you find payers are very motivated to drive quality improvement because this is where they're lagging. Their general performance is just not as good. They're not hitting their quality marks, and it's impacting their overall business performance. So there's a level of motivation that comes from the payers in these areas that's somewhat distinct from what you might find in other environments. Providers are similarly motivated because in many cases, they're struggling to find viable business models. I mean, we're seeing a very significant recession of primary care. We're seeing specialists that aren't being replaced as they retire. So there are some economic disincentives, and there's therefore an openness to consider alternate payment models, a willingness to partner that I'd say doesn't necessarily exist in urban and suburban competitive markets. And then, of course, we spoke about patients and their needs, and I think there's a newfound willingness to accept technology as a part of care, but that's rooted in a trust-based human relationship. And so as long as we protect that aspect of building trust and preserving it in support of quality, I think we're going to be able to bring patients along for the journey. So Homeward's approach has been to partner with payers in a value-based care construct to take full financial responsibility for a population in a given geographic area, and then to partner very closely with the providers in those areas, many of whom are not yet ready to take on risk. They don't have the infrastructure capability yet in place. They don't necessarily have the resources that they might need in order to execute on a value-based care model themselves. And so in partnership, we're able to bring those capabilities to them and very, very much focus on driving quality, because that is common ground. Providers want to deliver better quality, and there's good mechanisms for them to be compensated for that. It's of course in the interest of patients, and it's also having a direct bottom line impact on payers. And so by in a sense occupying that middle territory, and another point Carrie made, which I really liked, was, delivering some innovation in the coordination of the services that are available. These are overworked primary care doctors who maintain a very strong relationship with their patients, but don't have enough resources to do everything that they want to do. We have these community organizations that are building great programs and aren't able to reach their community members to inform them of what they're capable of offering. And then in the patient's own home, it's very, often the case that it's just not clear what their needs are. And so without being there, it's hard to make those judgments and provide those resources. So our approach at Homeward has been to really try to fill that gap, to be that entity that can sit in between, the glue in some ways, trying to bring these different stakeholders together. And in our experience, it's something that really can't be done without a significant investment in technology, because there's no other way to achieve scale because of the distribution of these populations.
Thanks, Mark. And Carrie, maybe turning to you a little bit, I believe you've done a fair bit of thinking on scaling. What are the policy challenges? What are some opportunities that you see for scaling a lot of these interesting rural home-based care models?
Yeah. So we are fortunate at NRHA, in partnership with the John A. Hartford Foundation, to have just this year created a national rural age-friendly interest group. And in our initial conversations, we've kind of identified 4 key areas for framing what our policy priorities will be in terms of advancing rural age-friendly environments and systems. So I think one of the most interesting and yet fundamental points that we really landed on was kind of a promotion of rural by choice, which I know sounds very kind of elementary, but we, I think, so often think about rural areas as being left behind, or places where people are and they can't leave for whatever reason. But we really want to focus on changing the narrative, in that rural areas are wonderful places to live. They're wonderful places to grow old. And many adults, older adults, are choosing to age in place given kind of the relationships and the communities that are in these rural areas. And so keeping, again, kind of at the core of all of this is wanting to build that rural by choice capacity, and really listening to the older adult and helping kind of our policymakers think about that in their work. We also really focused on the need to continue to build a robust workforce to support these populations, and that includes the clinical workforce, but it also includes important partners to that. It includes community health workers, and thinking about how we continue to make sure that and it includes caregivers. So thinking about how we are supporting kind of all elements of that. We talked a lot about alignment of all of the different sectors that are caring for an older adult population. So you've got kind of the aging community, you've got the clinical community, you've got these community-based organizations, whether that's around food or transportation or housings, and each of those kind of assets have their own kind of federal and state frameworks and plans. And so thinking about how we align that multi-sector approach, I think, is really critical. And then there are a number of regulatory barriers, both at the state and federal levels, that we really want to think about how we can break down. So one is sustaining services through supporting caregivers, and specifically inclusion of CHWs, and how do we pay for and bring a greater engagement of that provider population. We talked a lot about telehealth here already, but telehealth obviously is a critical part of that, and extending some of the flexibilities we saw during COVID-19 to continue being able to provide these services. We also talked about kind of coverage barriers and thinking about how we make sure older adults have healthcare coverage and can pay for services related to this. And then as we think about rural broadly, I think the last point is recognizing that home and community-based services are frequently a part of an entire spectrum of long-term care, and making sure that we are building and supporting that spectrum of, or building on supporting those facilities and providers throughout that whole spectrum, so that people really can kind of stay in their communities as long as possible throughout their lifetime. So those are a couple of high notes that I would share.
Great, thanks, Carrie. And just a quick time check. So we're almost at time, but maybe Beth and Kristen, I want to give you all an opportunity to give just sort of a final takeaway here. So Beth, what would be your top takeaway in terms of scaling and improving rural home-based care?
Well, I think Carrie is right on. I think that community health workers that have a long history in the rural space, so they're housed at rural health clinics, federally qualified health centers, and community hubs that work on social determinants of health. They're currently funded through really unsustainable, unstable grant cycles, local investments, and in our state, very small payment per visit, when actually where most of the work they do is not during the visit. It's preparing for it, it's linking to resources, moving to and from it, and contacting on the phone, etc. So I think it is time to look for viable long-term funding mechanisms that would support cost-saving services provided by community health workers as part of the care team.
Thanks, Beth. And Krista, I'm giving you the last word here. Your top takeaway.
I guess it would be, don't forget to ask for help. We have, in our office, Federal Office of Rural Health Policy, grants, technical assistance, all kinds of resources available all the time for free and on the application cycle. We're easy to find on the web. And not also there's going to be lots of stories and examples that may help with what folks are trying to work locally, both at ruralhealthinfo.fund. In addition, our office funds research centers. So ruralhealthresearch.org also has a curated array of resources that can really help folks see what's worked and see what's not worked in other areas. In addition, every state has a state office of rural health. They often have many of the connections you may be looking to make if you're trying to build a solution like this for your community.
Thanks,
And
Kristen.
yeah, don't give up. It's worth doing.
And that's a great way to end, that there are some resources out there. To give a quick summary, I think what I've heard, we've talked about a variety of examples where we're seeing some really interesting innovations in rural healthcare and rural home-based care. I think we've talked about what those models look like and how they're different than the urban, suburban areas type models. And I think we also talked about ways that we can help scale those further through various policy changes, through different types of payment models. And so maybe I know my colleague, Montgomery Smith, you have a slide you want to put up here for next steps. So we're going to follow up after this. We have a Duke Margolis side, have a home-based care, primary care newsletter. We'll also follow up on this webinar with a paper that summarizes many of the themes that we've heard from our research and drawing from the great discussion we had today. And I also want to thank Montgomery Smith and Jonathan Gonzalez-Smith for all their work putting this together. So with that, thanks everybody for joining us on this Tuesday morning, and we will all hope to hear from you all soon.